So Impella step by step. See, so we have extensively discussed about when to go ahead with hemodynamic support with Impella or other devices. So there are two situations as a cardiologist. One is anticipated hemodynamic instability while doing an intervention. So that is one indication for me where I can put an Impella. It's a preemptive Impella positioning, that is a protected PCI situation. The second situation is what we have been discussing since last 2 hours, that is pre-existing hemodynamic instability of cardiac origin. So either acute MI or acute myocarditis or acute heart failure in a chronic heart failure situation. So this is the algorithm to use this hemodynamic support devices in an high-risk PCI situation where we can place an Impella and also patient already on shock. So if there is only simple LV failure without RV failure or hypoxemia, which already we discussed, how to choose based on right heart catheterization. So in only LV failure situation with severe shock, so we can use an Impella device. And in a protected PCI situation, so where patient has at least 4 of these, score of 4 in this, that is hemodynamics and kind of presentation of patient and also procedure related risk. If the risk is if the score is more than 4, you can strongly think of preemptive Impella for these patients before PCI. And what is a checklist before Impella? So the most important is your aortic valve, because the device is across the aortic valve. There shouldn't be any prosthetic aortic valve. Our patient shouldn't have severe AR, because that precludes the benefit of your Impella pump. And next is presence of septal defects, either ventricular septal defect or atrial septal defect, which may cause right to left shunt, prevent increasing deoxygenation of blood and precluding the benefit of Impella. And also LV thrombus. So this may basically cause thromboembolization, and also thrombus can be sucked into device, leading to device malfunction. So these are the things which we have to rule out before embarking on Impella. And the next thing is vascular access. So make sure is your vascular access, is it the femoral or axillary or transcaval? So most often it is the femoral, and but if you are thinking of prolonged Impella support to the patient, probably mostly in a heart failure situation, probably axillary with better support. And if you have no access, maybe transcaval can be considered. And the accessible size is very important. It has to be at least more than 5 millimeters, which has to be confirmed before embarking on this procedure. And if you look at Impella pumps sizes, we have 2.5 CP and 5, and also Impella RP. So the size 2.5 is the 13 French sheath, and the CP is 14 French sheath, and Impella 5 is 21 French sheath. So Impella 5 is mainly for axillary. CP and 2.5 can be placed from even femoral sites. So coming to right heart catheterization, as Dr. Lee already mentioned, so it is always preferable to do right heart catheterization before placing this Impella device. And as you already mentioned, so PAPI, pulmonary artery pulsatility index, is the best measurement to decide whether the patient needs only LV support or patient also needs a right ventricular support. Based on that, we have to decide whether to go for a VA more Impella. So if the PAPI is more than 0.9, I think those are the patients where you can simply place Impella and do your rest of the procedure. So coming to vascular access, vascular access is very important. Technique is very important to prevent complications of these larger devices, larger sheets. So it's always better to use either ultrasound guided puncture or pigtail guided puncture, which we are well versed in structural heart intervention. So take a good anterior puncture by ultrasound or pictorial guided, and then put Parclose devices. This has been a right practice, for protected PCI situation where Impella is used, and it also helps in patients where uh, Impella was used for prolonged support in cardiogenic shock. Only risk is, risk of infection of these, uh, sutures lying there. So otherwise, two Parclose devices can be used, one at 10 and the other at 2 o'clock. Um, and then comes insertion of the Impella sheath. So commonly used Impella is Impella CP, whose sheath size is 14 French. And you can decide sheath size short or long based on tortuosity of your iliacs. If your iliac, femoroiliac portion is very tortuous, always go with a long sheath. Otherwise, you can go with a short sheath. So, and once sheath is pushed in, and then heparinize the patient to achieve a good ACT of more than 250 to avoid thrombus formation within the larger sheath. And it's always better to remove dilator after heparinizing and achieving a good ACT. And once the sheath is placed inside, the next immediate step is look for any limb ischemia on the same side. So on the MCS side, so either by Doppler or by routine pulse oxy measurement, saturations measurement, or also looking at the pulsations of distal limb. So if there is any evidence of limb ischemia, it's always better to consider a perfusion catheter to the distal limb. So you can have different combinations of perfusions. This is like an external ipsilateral circuit wherein you can use your Impella sheath. As the Impella size is 9 French, the main shaft. So you can use this sheath as pull out of blood, and then you can push into the distal circulation by another sheath into the SFA. So this is an external ipsilateral circuit. You can also use external contralateral circuit. This is pull blood from the others from opposite side and then push it through the ipsilateral sheath in the SFA. So, or you can use internal contralateral circuit. So here in MCS is from here, and from the opposite side keep a 7 French sheath, and through that you keep a 4 French sheath, and this 4 French sheath acts as blood flow to the opposite side. So this is an internal contralateral circuit, and also you can use a contralateral distal retrograde circuit, sucking blood from the other side and then pushing into the distal circulation on the ipsilateral side. So these are the various things which you can consider based on the anatomical situations in the patient. And once this is done, then go ahead with LV entry. So we can enter LV with the Amploger AL catheter with a straight tip wire, and then push the Amploger catheter into the LV, and then exchange the wire with exchange the catheter to the pigtail, and then take 018 wire, so which is there in the Impella kit, after giving a good loop at the tip, and position it along the apex into the LV. So once 018 wire is in the LV, then go to your next step, that is Impella loading. So Impella loading, there is a easy guide lumen which is present within the Impella. You can see this. This is the red one is the easy guide lumen. So which comes out of your outflow. So this is the Impella outflow in which goes which stays in the aorta. So this is for easy wiring, and this is very, very important. So once your wire is in, so once you wired, so you have to remove this easy guide lumen. So thread the Impella over the wire, and then remove this easy guide lumen. Otherwise, if it goes in and you start Impella on, you will end up in this Impella struck with this easy guide lumen. So load it, remove easy guide lumen, and then insert into sheath. So when you are inserting, this proximal, that is the inflow, goes into sheath first, and the outflow is outside. So there will be a tremendous blood flow out. So that's the reason you try to insert Impella quite fast up to the outflow into the sheath. So that's one caution, which we have to follow. So, and once Impella is in, so we can slowly push it into the LV or the point 018Y. So once it entered into the LV, the next important step before you start off is removal of the wire. You can see here, so this is the 018Y. So this wire comes out of outflow. So if you start off Impella without removing this wire, you will end up in damaging this Impella and may lead to device malfunction. Make sure you removed 018Y and then check your position and also check your connection. So right now the device which is available in India, so it shows only one pressure wave, that is aortic pressure wave, and the second one is the motor current wave. So this dichrotic aortic pressure wave and this pattern of motor current wave says the position is correct. So once the position is checked, then you can establish other connections and purge connections, and then you can move on to beginning Impella. So you can see various patterns of pressure. So this is right, aortic, dichrotic notch, and motor current, which says Impella is, right position. And here you can see the LV pressure wave. So that means Impella is actually pushed into the LV. And yes, if the motor current wave is absent with an aortic pressure wave, then we can say Impella is actually back into the aorta. So based on that, we can check positions, and we can adjust position of Impella. And coming to the setting flow, so you have three options here. So auto flow option. So in auto flow option, here motor speed is set to achieve maximum possible flow without causing any suction. So, and this is what we use most often in protected PCI situation, but this works for only 3 hours. After 3 hours, automatically device switches to a P level, which was set, which was preset. So in a P level, so here we can have different options from P0 to P8. P0 means no flow, P8 means almost the maximal flow. And we have another option like boost, so wherein we can use quickly we can increase a maximum flow, and which stays for 5 minutes, and then it goes back to auto setting or your P level flow. So these are various P level flow rates in an Impella CP catheter. You can see P0 is no flow, P1 is 0 to 1.7 liters. And it all depends on patient volume status and position of the Impella. So, and also pressure. So P2 is 1 to 2.1, and P8 is basically 3 to 3.3 liters. So this is the flow pattern which you will get with prefixed flow rates in Impella CP catheter. A boost is something where you'll go to the maximal flow which can be achieved in that patient, and which stays for 5 minutes. So to show you as an example, in this case, where while doing LMCA bifurcation angioplasty, patient just went into no flow for a brief period of time, and that's when. So what exactly happened is, you can see this is the aortic normal pressure wave. And here there is a complete loss of pressure wave. There is no pressure wave of aorta. So which says ventricular arterial uncoupling in this situation. So, and these are the situations which you can basically circumvent mortality by having this device in place. So, and once we quickly completed the patient's procedure, yeah, and we achieved this good result, and which led to almost a great savior on that day. And yeah, once you started on Impella, and then you should have an exit strategy, and that is Impella weaning and explanting. So the in a protected PCI situation, it is quite easy. Post procedure, you can start reducing flow rates based on patient's mean arterial pressure, and yeah, so as the mean arterial pressure is maintaining, you can come down from PI to gradually to P0, and if the still pressures are maintaining and patient is hemodynamically stable, so and once it comes to P2, you can uh, once it comes to P1, you can pull the catheter into the aorta and then stop the Impella, and then you can explant. You can remove it from sheath. So yeah, so once it is, which you can see here, so I'm just pulling Impella back into the aorta, and then we'll switch off, and then we'll remove. So after withdrawal through the P-level sheath, so we can remove P-level sheath and then tighten the knots which were placed before the procedure. So, and you can see for any ischemia in that vessel. But if patient is, the situation is cardiogenic shock, or even after PCI, patient has hemodynamic abnormality, then you have to prepare patient to shift to ICU with Impella. So this is when these steps are very important. So here, before shifting, so we have to remove this P-level sheath. So pull the P-level sheath completely out of your puncture site, and ask your assistant, scrub assistant, to put pressure on puncture site, so for not allowing to bleed, and then split your sheath and remove it. So once P-level sheath is removed, there is another sheath, slide repositioning sheath, which is present on the Impella, which can be pushed into the groin. So this is very important, because this P-level sheath, as the size, as the tip of the sheath is 14 French, so it allows continuous blood flow inside, and also causes clot formation, and which leads to more vascular complications. So by changing this P-level sheath to a repositioning sheath, we can reduce vascular complications. So once sheath is changed, then we can lock the position of Impella, and then secure anti-contamination sleeve, and then shift the patient to ICU. In ICU, as we already discussed before, and patient needs a regular monitoring. So you have to monitor Impella function and its position by using pressure waves and motor current waves, and also pulse pressure wave. Assessment of cardiac power output to decide on wean off, as already extensively discussed by Dr. Lee. And groin management and bleeding issues needs a special attention, and distal limb ischemia assessment, periodic assessment needs a special attention, and ACT monitoring and anticoagulation. So these are the things which has to be done in ICU on a periodic basis to make it less, to reduce complications, because that is very important. Most of the data shows, the benefits are basically undermined by the complications of these devices. Only when we minimize complications by extensive monitoring of these patients, then the benefit of these devices will be exposed better. And bleeding troubleshooting, so maintain only ACT around 160 to 180. So if the ACT is more, try to adjust your heparin doses, and then have a look whether P-level sheath is removed or not, and then minimize unnecessary movement of patient, and use like immobilizer to reduce trauma to access site. So like here, and also check forward suturing of repositioning unit. So your position of this hub, Impella hub, should be like this. So when the angle is maintained, the chances of bleeding also will be less. And ischemia troubleshooting, uh, uh, increased likelihood of pill away introducer sheath is left in place. If this is not removed, chances of clot formation and ischemia is very high. So this needs an attention. And whenever there is an ischemia, and make sure you are going to perfuse distal limb by already mentioned techniques. So initiate weaning. So, and most of the patients typically you can start weaning in 48 hours. And see, uh, before weaning of these devices, make sure, so all the vasoactive drugs are already removed, withdrawn. Otherwise, and optimize hemodynamics by using mechanical circulatory support devices, and also reducing vasoactive medications, so that their left ventricular cardiac output is uh, cardiac power output is more than 0.6 watts, and cardiac index is more than 2 liters, and the PCWP is less than 15 mmHg, and PAPI is more than 1.05, and CBP is less than 15 mmHg. And then make sure organ perfusion is good, both clinically by appropriate mental status of the patient and adequate urine outputs, and warm and well perfused extremities, and as well as biochemical parameters like lactate less than 2, mixed venous oxygen saturation more than 60, and normalization of acid base status, and normalization of pH and bicarbonate, and minimization of base deficit. So once these goals are achieved, and also the reason for this insult is treated, like revascularization in the setting of ischemia, or correction of arrhythmias, or or any other anatomic issues. So to conclude, so choose a right patient for Impella, and most rule out aortic valve issues and LV clot and subtle defects before embarking on this device, and select a right axis based on your indication, and also confirm the size of the vessel before you puncture it. And vascular access and its management needs a special attention in these patients to minimize complications and maximize the benefit of these devices. And in cardiogenic shock scenario, so sheath exchange is very crucial before shifting patient into ICU, and ACT monitoring bleeding complications needs attention. And weaning of Impella protocol is very, very important to make your exit more and more easy. Thank you.